Hello, seniors. I am Dr. Robert Harrison. Here's something that surprises most people over 60. Your vitamin B12 blood test can look completely normal while your nervous system is quietly getting worse. I'm talking about balance problems that lead to dangerous falls, memory issues brushed off as just aging, and numbness or tingling in your hands and feet that slowly spreads over time. The scary part, there's a specific reason standard lab tests miss this disconnect between normal results and worsening symptoms. And once you understand it, it could completely change how you think about B12 supplementation. I'm Dr. Michael Kent, and in the next 15 minutes, I'm going to walk you through the absorption barrier that makes standard B12 supplements ineffective for many older adults, why the form of B12 matters far more than the dosage, and the specific delivery method that bypasses age-related absorption problems altogether. If you're currently taking B12 but still experiencing unexplained fatigue, cognitive changes, balance issues, or other neurological symptoms, this information is especially important for you. Before we continue, leave a comment with your age and your current B12 routine. Are you taking it daily, and what form are you using? Your experience helps others and helps build our community's shared understanding. Research published in the American Journal of Clinical Nutrition indicates that approximately 40% of adults over 60 have suboptimal B12 status despite consuming adequate amounts through diet or supplements. The challenge isn't intake, it's absorption. And this distinction matters profoundly for long-term neurological health. Robert, age 68, has been taking 1,000 micrograms of B12 daily for 5 years. His annual physical shows B12 levels at 380 picograms per milliliter, which falls within the standard reference range of 200 to 900. His physician reviews the results and confirms everything looks normal. Yet, Robert continues experiencing progressive numbness in his feet, episodes of unexplained dizziness, and difficulty with word recall that wasn't present 2 years ago. This represents a common gap in how we interpret B12 adequacy. The standard blood test measures total B12 in circulation. It does not measure cellular uptake or active utilization at the tissue level, particularly in nerve cells where B12 performs its most critical functions. The consequences of inadequate B12 utilization extend beyond temporary fatigue. According to research in neurology, chronic B12 deficiency can cause irreversible nerve damage. The myelin sheath, which insulates nerve fibers and enables rapid signal transmission, depends on adequate B12 for maintenance and repair. When myelin deteriorates, nerve signals slow down or fail to transmit properly. Early symptoms include peripheral neuropathy characterized by tingling, numbness, or burning sensations in the extremities. As the deficiency progresses, balance and coordination deteriorate, cognitive function declines, and in severe cases, permanent neurological impairment can occur. What makes this particularly concerning for older adults is the time frame. Nerve damage from B12 deficiency develops gradually, often over years. By the time symptoms become severe enough to prompt medical investigation, significant deterioration may have already occurred. Studies indicate that neurological damage present for longer than 6 months becomes increasingly difficult to reverse even with aggressive B12 replacement therapy. The standard approach, taking a B12 tablet once daily and checking blood levels annually, misses the fundamental problem. Absorption capacity declines with age due to multiple physiological changes that we'll examine in detail. This means the usual supplementation strategy may provide reassuring lab numbers while failing to deliver adequate B12 to the tissues that need it most. Here's what's interesting. The solution isn't necessarily taking more B12. It's understanding the absorption pathway and working with your body's changed physiology rather than against it. Research published in the Journal of the American Geriatric Society demonstrates that sublingual B12 administration can achieve therapeutic levels in older adults who show poor absorption with standard oral tablets. This suggests the problem isn't the vitamin itself, but the delivery method we've defaulted to using. The contrarian insight here challenges a common assumption in supplement use that if some is good, more must be better, and if oral doesn't work, injections are the only answer. In reality, the research indicates that changing the form and delivery method often produces better results than simply increasing the dosage of a poorly absorbed product. Understanding why this works requires looking at what changes in your digestive system after 60 and how those changes specifically interfere with B12 absorption. This represents a shift from viewing B12 supplementation as a simple nutrient replacement to understanding it as a physiological challenge that requires strategic adaptation. And once you understand the mechanism, the solution becomes remarkably straightforward. To understand why B12 absorption declines with age, we need to examine the multi-step process that occurs from the moment you swallow a B12 supplement until it reaches your bloodstream and eventually your nerve cells. When you consume B12, whether from food or a standard tablet, it arrives in your stomach bound to proteins. Your stomach must produce two critical factors for B12 absorption to proceed. First, hydrochloric acid separates B12 from its protein carriers. Second, a glycoprotein called intrinsic factor, produced by parietal cells in the stomach lining, binds to the freed B12 molecule. This B12 intrinsic factor complex then travels to the small intestine where it attaches to specific receptors in the ileum and gets absorbed into the bloodstream. This process works efficiently in younger adults. However, multiple age-related changes disrupt this pathway. According to research in the American Journal of Clinical Nutrition, approximately 10 to 30% of adults over 50 develop atrophic gastritis, a condition characterized by chronic inflammation of the stomach lining. Atrophic gastritis reduces the number of functioning parietal cells, which directly decreases both stomach acid production and intrinsic factor synthesis. The decline in stomach acid has two consequences for B12 absorption. First, inadequate acid means dietary B12 remains bound to food proteins and cannot be released for absorption. Second, lower acid levels allow bacterial overgrowth in the stomach and small intestine. These bacteria consume B12 before your body can absorb it, further reducing available amounts. The reduction in intrinsic factor creates an even more significant barrier. Studies indicate that intrinsic factor secretion can decline by 50% or more in older adults with atrophic gastritis. Since the B12 intrinsic factor binding is essential for absorption through the ileal receptors, this dramatically limits how much B12 can enter your bloodstream, regardless of how much you consume. Additionally, many older adults take medications that further impair B12 absorption. Proton pump inhibitors and H2 receptor antagonists, commonly prescribed for acid reflux, suppress stomach acid production. Metformin, widely used for type 2 diabetes management, may interfere with B12 absorption through mechanisms that are not fully understood but appear to involve alterations in small intestinal motility and bacterial balance. Long-term use of these medications has been associated with increased risk of B12 deficiency in multiple studies. Margaret, age 72, takes omeprazole for chronic reflux and metformin for prediabetes. She diligently takes a standard B12 supplement every morning with breakfast. Despite this routine, she continues experiencing fatigue and occasional cognitive fog. The explanation lies in the compounding effects of reduced stomach acid from aging, further suppression from her proton pump inhibitor, and potential interference from metformin. Her supplement dissolves in her stomach, but the B12 molecules cannot be adequately separated from the tablet, bound to intrinsic factor, or efficiently absorbed even if they reach the small intestine. The supplement passes through her digestive system largely unutilized, providing minimal benefit despite her compliance. This explains why simply taking more of the same supplement often fails to resolve symptoms. The problem isn't dosage, it's the absorption pathway itself. Now that we understand the absorption barrier, let's examine why the specific form of B12 in your supplement matters profoundly. If you examine most B12 supplements available in pharmacies and grocery stores, you'll find one name appearing repeatedly: cyanocobalamin. This is the synthetic form of B12 created by attaching a cyanide molecule to the cobalamin structure. It's inexpensive to manufacture, extremely stable during storage, and has been used in supplements for decades. However, cyanocobalamin is not the form your body actually uses to function in nerve tissue, energy metabolism, and DNA synthesis. B12 must be in one of two active forms, methylcobalamin or adenosylcobalamin. Your liver must convert cyanocobalamin into these active forms through a multi-step enzymatic process that requires adequate glutathione, adequate ATP, and properly functioning enzyme systems. In younger adults with optimal liver function and robust antioxidant capacity, this conversion proceeds efficiently. However, studies published in the Journal of Nutrition indicate that conversion efficiency declines with age. The enzymatic systems responsible for this transformation slow down. Glutathione levels which support the conversion process tend to decrease in older adults. Chronic conditions common in aging, such as mild fatty liver or reduced hepatic blood flow, further impair the liver's ability to convert synthetic B12 into active forms. This creates a paradox. You may be consuming adequate cyanocobalamin, and it may even raise your blood B12 levels to normal or high ranges on standard testing, but your nerve tissues still aren't receiving adequate active B12 for cellular function. The blood test shows total B12, which includes both inactive and active forms, as well as B12 analogs that cannot be utilized. It does not distinguish between forms or measure what's actually reaching your mitochondria and supporting myelin synthesis. The research on active B12 forms demonstrates clearer outcomes. Studies comparing methylcobalamin to cyanocobalamin in older adults with peripheral neuropathy show that methylcobalamin produces more consistent improvements in nerve conduction velocity and symptom reduction. Methylcobalamin appears to cross into neural tissue more readily and provides the specific methyl groups needed for myelin maintenance and neurotransmitter synthesis. Adenosylcobalamin plays a distinct role in mitochondrial energy metabolism. It's required for the conversion of methylmalonic acid to succinyl-CoA, a step essential for cellular energy production. Elevated methylmalonic acid levels, which indicate functional B12 deficiency at the cellular level, correlate more closely with neurological symptoms than total serum B12 levels. Using adenosylcobalamin directly bypasses the need for hepatic conversion and ensures this metabolic pathway receives adequate cofactor support. Thomas, age 70, has been taking 2,500 micrograms of cyanocobalamin daily for 3 years. His blood work shows B12 levels at 850, well above the reference range. Yet he continues experiencing balance difficulties and cognitive slowing when his physician checks his methylmalonic acid level. It comes back elevated at 450 nanomoles per liter when optimal levels should be below 270. This elevated MMA indicates that despite high circulating B12, his cells aren't receiving adequate active B12 for metabolic function. Switching to methylcobalamin and addressing his absorption issues allowed his MMA levels to normalize over subsequent months, and his neurological symptoms gradually improved. The form you take determines how much active B12 actually reaches your tissues. Understanding the absorption barrier and form factor problems leads us to the most practical solution for most older adults: sublingual delivery of active B12 forms. This approach bypasses the stomach acid and intrinsic factor requirements entirely. Sublingual administration means placing the B12 tablet or lozenge under your tongue and allowing it to dissolve slowly over several minutes. The mucous membranes under the tongue contain a rich network of blood vessels close to the surface. B12 molecules can pass directly through these membranes into the bloodstream through passive diffusion and active transport mechanisms that don't require intrinsic factor. Research published in the British Journal of Clinical Pharmacology demonstrates that sublingual B12 absorption can achieve blood levels comparable to intramuscular injection in many individuals. A study comparing 2,000 micrograms of sublingual methylcobalamin to 1,000 microgram intramuscular injections found similar increases in serum B12 levels over 4 weeks in older adults with absorption impairment. The key to effective sublingual absorption is proper technique. The tablet must remain under the tongue for adequate contact time, typically 5 to 10 minutes. Swallowing too quickly defeats the purpose, as the B12 then enters the standard digestive pathway where absorption barriers apply. Drinking water or eating immediately after placing the tablet reduces contact time and decreases absorption efficiency. For individuals who find holding a tablet under the tongue uncomfortable, liquid sublingual B12 formulations provide an alternative. These typically come with a dropper, allowing precise dosing and easier administration. The liquid spreads more evenly across the sublingual tissue, potentially enhancing absorption surface area. Timing of sublingual B12 administration matters less than with oral tablets since you're bypassing digestive factors, but consistency remains important. Taking B12 at the same time daily, preferably in the morning or early afternoon, establishes a routine that supports compliance. Some individuals report feeling more alert after taking B12, so late evening administration might interfere with sleep quality in sensitive individuals. Dosage recommendations for sublingual B12 in older adults typically range from 1,000 to 2,000 micrograms daily. This is substantially higher than the recommended dietary allowance of 2.4 micrograms. But the higher dose compensates for incomplete absorption even through sublingual routes and provides adequate amounts to saturate transport mechanisms and ensure sufficient delivery to tissues. Linda, age 65, has been experiencing progressive fatigue and occasional episodes of confusion. Her B12 level is 320, technically normal but on the lower end. She's been taking 500 micrograms of cyanocobalamin tablets daily, swallowing them with breakfast. Her physician suggests trying 1,500 micrograms of methylcobalamin sublingually each morning. Linda follows the protocol carefully. Each morning after brushing her teeth, she places the sublingual tablet under her tongue and lets it dissolve completely over about 8 minutes, avoiding swallowing until the tablet fully dissolves. She maintains this routine consistently for 8 weeks. At follow-up, her B12 level has increased to 680. And more importantly, her methylmalonic acid level, which was elevated at 380 initially, has decreased to 240, indicating improved cellular B12 status. Over the subsequent 3 months, her energy level improves noticeably and the confusion episodes become less frequent. The improvement in MMA levels confirms that B12 is now reaching her cells effectively, not just circulating in her blood. While optimizing B12 form and delivery addresses the primary absorption challenge, several supporting factors determine overall effectiveness. Understanding these helps maximize results and avoid common mistakes that limit benefits even with improved supplementation. First, hydration status significantly affects nutrient transport and cellular uptake. Research indicates that older adults have reduced thirst perception and are at higher risk for chronic mild dehydration. Even slight dehydration impairs nutrient delivery to peripheral tissues, including nerve cells. If you're taking sublingual B12 but consuming minimal fluids throughout the day, your results will be suboptimal. Aim for adequate hydration based on your individual needs, typically 6 to 8 glasses of water daily unless medically contraindicated. Second, B12 doesn't function in isolation. It works in concert with folate and vitamin B6 in critical metabolic pathways, particularly the methylation cycle essential for DNA synthesis, neurotransmitter production, and homocysteine metabolism. Deficiency in folate or B6 can create functional B12 deficiency even when B12 levels are adequate. However, be cautious with synthetic folic acid, which some individuals metabolize poorly. Methylfolate, the active form of folate, is generally better utilized particularly in individuals with MTHFR genetic variations that impair folate metabolism. Third, consistency matters more than intermittent high doses for nerve tissue repair. Your nervous system doesn't store large B12 reserves the way your liver does. Nerve cells require steady, reliable B12 availability for ongoing myelin maintenance and neurotransmitter synthesis. Taking B12 only when you feel tired or every few days creates fluctuating availability that doesn't support the continuous repair processes your nerves need. Daily consistent supplementation provides the steady substrate your nervous system requires. Fourth, medication interactions require attention. Beyond the previously mentioned proton pump inhibitors and metformin, certain antibiotics, particularly those affecting gut bacteria, can disrupt B12 production by intestinal microbes and absorption. Nitrous oxide, sometimes used in dental procedures, can inactivate B12 and precipitate acute deficiency in susceptible individuals. If you undergo dental or surgical procedures involving nitrous oxide and experience new neurological symptoms afterward, discuss B12 assessment with your physician. Fifth, alcohol consumption affects B12 status through multiple mechanisms. Alcohol damages the gastric mucosa, reducing intrinsic factor production. It impairs pancreatic function, which affects B12 release from binding proteins. It increases urinary B12 excretion. Regular alcohol consumption, even at moderate levels, can contribute to B12 inadequacy in older adults already facing absorption challenges. Sixth, monitoring progress requires looking beyond blood tests. Yes, checking B12 levels and methylmalonic acid can provide objective data, but pay close attention to functional symptoms. Are your energy levels more stable? Has the tingling in your feet decreased? Is your balance improving? Are you experiencing fewer episodes of mental fog? These subjective improvements often precede significant changes in lab values and provide more meaningful measures of whether your B12 protocol is actually supporting your neurological function. A common mistake is judging the effectiveness of B12 supplementation only by how you feel in the first few days or weeks. Nerve tissue repair is slow. Myelin regeneration occurs gradually over months, not days. Some individuals notice improved energy within a few weeks as B12 supports cellular metabolism, but structural nerve improvements typically require consistent supplementation over 3 to 6 months or longer. Patience and consistency are essential. While optimizing B12 intake addresses one important factor in neurological health, it's essential to understand when other issues require attention. Not all numbness, tingling, fatigue, or cognitive changes result from B12 deficiency alone. Assuming B12 supplementation will resolve all such symptoms can delay diagnosis and treatment of other significant conditions. Peripheral neuropathy has multiple potential causes beyond B12 deficiency. Diabetes and prediabetes are among the most common, affecting an estimated 30 to 50% of individuals with long-standing diabetes. Elevated blood glucose damages small blood vessels that supply peripheral nerves and causes direct metabolic injury to nerve cells through multiple pathways. If your hemoglobin A1C is elevated or your fasting glucose is consistently above optimal ranges, addressing blood sugar control is essential for nerve health. Regardless of your B12 status, cervical spine degeneration can cause symptoms similar to B12 deficiency, including numbness and weakness in the hands, balance problems, and even subtle cognitive changes if spinal cord compression affects blood flow. Distinguishing between peripheral neuropathy from B12 deficiency and cervical myelopathy from spinal stenosis requires careful clinical evaluation, often including imaging studies. Hypothyroidism produces fatigue, cognitive slowing, and cold intolerance that can mimic B12 deficiency symptoms. Checking thyroid function through TSH and free T4 testing helps rule out this common condition in older adults, particularly women. Chronic inflammation from any source interferes with nerve function and nutrient utilization. Inflammatory markers like C-reactive protein, when chronically elevated, correlate with increased risk of cognitive decline and peripheral nerve dysfunction independent of vitamin status. Addressing sources of inflammation, whether from poor sleep, chronic stress, sedentary lifestyle, or underlying inflammatory conditions, supports overall neurological health. Certain medications beyond those affecting B12 absorption can cause peripheral neuropathy directly. Chemotherapy agents, some antibiotics, and certain cholesterol medications have known neurotoxic effects. If you develop neurological symptoms after starting a new medication, discuss this timing with your prescribing physician. Let's bring together everything we've covered into a clear, actionable protocol you can implement starting today. This represents a research-informed approach to B12 supplementation specifically designed for the physiological realities of aging. Step 1. Evaluate your current B12 form and delivery method. If you're taking cyanocobalamin tablets that you swallow, recognize that this approach may not be optimal for your age-related absorption capacity. Consider switching to methylcobalamin or a methylcobalamin-adenosylcobalamin combination in sublingual form. This change alone often produces noticeable improvements within several weeks to a few months. Step 2. Implement proper sublingual technique. Place the tablet under your tongue and allow it to dissolve completely, typically 5 to 10 minutes. Avoid swallowing, drinking, or eating during this time. This maximizes direct absorption through oral mucosa and bypasses the stomach acid and intrinsic factor requirements that decline with age. Step 3. Establish a consistent daily routine. Take your sublingual B12 at the same time each day, preferably morning or early afternoon. This creates a habit that supports compliance and provides steady B12 availability for nerve tissue maintenance. Don't skip days or take it only when you feel tired. Nerve repair requires consistent substrate availability. Step 4. Use an appropriate dosage. For most older adults with absorption challenges or existing neurological symptoms, 1,000 to 2,000 micrograms of sublingual methylcobalamin daily represents a reasonable starting point. This is substantially higher than the RDA, but it compensates for incomplete absorption and ensures adequate tissue delivery. B12 is water-soluble and excess amounts are excreted safely in urine. Work with your healthcare provider if you have specific health conditions or concerns about appropriate dosing. Step 5. Support B12 function with complementary nutrients. Ensure adequate folate intake, preferably from food sources like leafy greens, or use methylfolate supplements if needed. Vitamin B6 also plays important roles in the same metabolic pathways. However, avoid megadoses. Balance is more important than excess.